Okay, so I'm going to do chapter 15 and 16 in one big video. I just wanted to make sure that my IT stuff was going to work because I haven't done recorded slides in a long time, mostly because I hate listening to myself teach them. So, and I thought I already had these slides recorded, but I didn't. So we're starting over, but it's all good. So host response to plaque biofilm. And we've kind of already covered a little bit of this. We've talked about host response a lot and tipping the scales, but the presence of periodontal pathogens alone is insufficient to cause tissue destruction seen in periodontitis, right? We know this. Not every case of gingivitis is going to progress to perio. One person can have a lot of plaque biofilm and have no destruction. Another person can have a little bit and a lot of destruction. Really just depends on that host response. But we're just going to kind of dive a little deeper into what that means. It is the body's response to the periodontal pathogens that is the cause of nearly all of the destruction seen in periodontitis. The way that the body responds to periodontal pathogens is known as the host response. The prime purpose of the human immune system is to defend the life of the individual, the host. In the instance of periodontal disease, the immune system strives to defend the body against the bacteria present in plaque biofilm. Okay, the body's defenses are employed to save the life of the host, not to preserve the tooth or its surrounding periodontal structures. Okay, so the body's immune system is just like, at all costs, we have to get away from this bacteria. Okay, it's not seeing it as like, oh, and in the process, we're causing destruction. Okay, factors that enhance the microbial challenge, the virulence factor. Okay, all of the mechanisms that enable biofilm bacteria to colonize and damage tissues. Virulence factors, they may be either structural characteristics of bacteria or substances produced by bacteria. Okay, so the presence of lipopolysaccharides, okay, that basically just makes the bacteria a lot harder to kill. The ability to invade tissues and the ability of the bacteria to produce enzymes, okay? All of those things are going to make it harder for the body to fight them, okay? Some factors influence the host's susceptibility to periodontal disease. May modify response or tissue metabolism. Okay, so this can be genetic, it can be environmental, like tobacco smoking, it can be acquired, like type 2 diabetes. Okay. The protective host response can turn harmful in inflammation. Okay, so acute inflammation is the first line of defense against a microbial invasion. After microbial challenge has been eliminated, the host must be able to shut down the response, just like we talked about in the last chapter. The resolution of acute inflammatory response must be effective. Periodontitis is associated with unresolved inflammation, okay? So the body has to be able to not only effectively take care of the bacteria, okay, with the right immune response, and the immune response being strong enough to take care of the bacteria, but it also has to know when enough is enough. And if it doesn't, and it doesn't shut off, then we go from acute inflammation to chronic inflammation, okay? The resolution of inflammation is an actively regulated biologic process, okay? The return to homeostasis is called catabasis, okay? The process of catabasis is complicated as the onset of inflammation. Okay, so it's just as hard to turn it off as it is for the body to have a correct immune response. Pro-inflammatory mediators like PMNs are recruited during the acute phase. Overproduction of these mediators cause destruction of connective tissue matrix and resorption of bone. Pro-resolving lipid mediators are produced to terminate the PMN recruitment, okay? Chronic inflammation occurs if the host is unable to stop the recruitment of PMNs, which has pathologic effects on the host, like we talked about, destroys the connective tissue and surrounding bone. Okay, so this is just a little flow chart. We have the microbial invasion. leads to acute inflammation. The host produce pro-resolving lipid mediators, the resolution of inflammation, protection from further inflammatory damage, stimulation of tissue regeneration or repair, and return to homeostasis, okay? That is if everything goes well, we flow into the green. But if we have that acute inflammation and we go straight down into the red and we get that sustained chronic inflammation because it's unresolved, then that's when our body's immune system cannot properly respond, okay? So that's where we end up with things like periodontal disease, diabetes, cardiovascular disease, rheumatoid arthritis, COPD, neurological disorders, and organ fibrosis, okay? Inflammatory biochemical mediators of the host response. These biochemical mediators are biologically active compounds secreted by the immune cells that activate the body's inflammatory response, okay? So the mediators are like the middlemen. The biochemical mediators are the middlemen sent by the immune system to activate the inflammatory response. Like we talked about in the last slideshow, the inflammatory mediators of importance in periodontal disease, okay, are cytokines, prostaglandins, and MMPs, okay? Make a flashcard with that on it. It will be a test question. It will most likely be a board question. That one in understanding the 3 interleukins and the TNF alpha, okay? Really understanding those is very important. The cytokines are powerful mediators produced by immune cells. They influence the behavior of other cells. So they're going to signal to the immune system to send more phagocytes to the site of the infection. Okay. They're produced by many different cells: PMNs, macrophages, B lymphocytes, epithelial cells, gingival fibroblasts, and osteoblasts. They're produced in response to tissue injury. And cytokines, important in periodontal disease, include interleukin 1, interleukin 6, interleukin 8, and TNF alpha, okay? So really important to understand that those are our 4 cytokines, okay? Interleukin 1, interleukin 6, interleukin 8, and TNF alpha, okay? The functions of the cytokines are to recruit PMNs and macrophages to the infection site, okay? They increase the vascular permeability that increases the movement of immune cells into the tissues, and it can initiate tissue destruction and bone loss in chronic infections such as periodontal disease, okay? So remember when we talked about can't stop the recruitment of the PMNs, then they just continue to destroy the connective tissue and alveolar bone. Okay, prostaglandins are also powerful inflammatory mediators. There is a series of prostaglandins, D, E, F, G, H, and I, and most cells can produce the prostaglandins. The function of them is to increase permeability and dilation of blood vessels to promote increased movement of immune cells and complement the infection site. They trigger osteoclasts, the bone-consuming cells, to destroy alveolar bone. And they promote the overproduction of destructive MMP enzymes. Prostaglandins of the E series, so PGE, initiate most of the alveolar bone destruction in periodontitis. Again, really important to understand that PGE is going to be the prostaglandin that causes most of the alveolar bone destruction in periodontitis. Okay, so our MMPs, this is a family of at least 12 different enzymes produced by various cells of the body. Again, our PMNs, macrophages, fibroblasts, and junctional epithelium cells. The enzymes act together to break down the connective tissue matrix. In health, MMPs facilitate normal turnover of periodontal connective tissue matrix. MMPs are released in attempts to kill invading bacteria, but it's the overproduction of the MMPs that result in breakdown of connective tissue of the periodontium. So if everything is balanced, like we talked about, and we don't get that overproduction of MMPs, then we're not going to get the destruction of connective tissues, okay? So MMPs in chronic bacterial infections High MMP levels result in extensive collagen destruction in the periodontal tissues. Without collagen, the tissues of the gingiva, PDL, and supporting alveolar bone degrade. This results in gingival recession, pocket formation, and tooth mobility. Because what are we seeing without collagen is we get apical migration of the junctional epithelium, okay? The current theory of pathogenesis. So pathogenesis that leads from health to gingivitis to periodontitis is complex and multi-layered. We've talked about that a lot, talked about a lot of the different theories. But the microbial infection activates the host response. Genetic and environmental factors modify the inflammatory response, and then the mediators are produced by the cells of the inflammatory response, okay? So we have our 4 histologic stages in development of periodontal disease: the initial lesion, early lesion, established lesion, and advanced lesion. This is what you guys are going to write your research paper on. It's going to be due on the 20th. I'm going to just double check that date with my little calendar here. Yep, Wednesday the 20th. We're moving that from the 13th to the 20th, remember? So you're going to pick a phase of the histologic stage of periodontal disease. You're going to research it, and you're going to talk to me about it, okay? So the initial lesion is our bacterial accumulation. The bacteria colonize the teeth near the gingival margin. We have our gram-negative bacteria, and their metabolites initiate the host response. Junctional epithelium cells release a biochemical mediator to stimulate the immune response. The PMNs pass from the blood vessels into the connective tissues, and as the PMNs pass into the connective tissue, they release our cytokines, okay? And the initial location of plaque is at the gingival margin. The gingival curvicular fluid increases in volume. Clinically, the tissue still looks pretty healthy. The host response is successful if most of the bacteria are destroyed. The body can repair any damage, and if the pathogens are not controlled, early gingivitis, like acute gingivitis, develops. So this is just a picture of the bacterial colonization near the gingival margin. We get the increased vascular dilation, okay? And the PMNs are going to migrate into the gingival sulcus, okay? So you can see the PMNs coming out of the blood vessel into the gingival sulcus here, okay? Okay, and then when we reach that next phase, the early lesion, early gingivitis, biofilm maturation continues and bacterial toxins and bioproducts penetrate the junctional epithelium. The cytokines attract more cellular defenders to the site, and increased permeability of blood vessels allow more PMNs to move into the connective tissue and form a wall between the biofilm and the sulcus wall, okay? The PMNs release the cytokines that cause localized destruction of the connective tissue. Macrophages are recruited to the connective tissue and release cytokines and MMPs. MMPs are responsible for excessive loss of connective tissue. Louder for the people in the back. Remember, we want to remember MMPs are responsible for excessive loss of connective tissue. Sulcular epithelium forms epithelial ridges, and junctional epithelium cells proliferate. Clinically, edema, which is fluid-filled tissue, and redness, which is erythema, right, of gingival margin tissue is observed. Initiation of good self-care can mechanically disrupt the plaque biofilm for a complete return to health. The body can still repair any damage. If the immune system fails to shut off the response, the lesion progresses to the established lesion. So again, gingivitis, completely reversible by good self-care and mechanical destruction of the plaque biofilm. Okay, the body can repair any damage that's done there. If some of the more coronal cells of the junctional epithelium have lost their collagen and they've migrated away from the tooth, the base of the junctional epithelium is still attached to the tooth and has not migrated apically, okay? So we might have some of those like 4 millimeter pockets, whether it be from a pseudomembrane or the most coronal cells of the junctional epithelium moving away from the tooth, but that can still be repaired. There is no perio yet, okay? But if the immune system fails to shut off the response, that's when our lesion is going to progress to establish gingivitis, okay? So the bacteria penetrate into the connective tissue, okay? We can see it's no longer just in the sulcus that we see these green bacterial cells, but they're down into these connective tissue layers, okay? More PMNs are attracted to the site. They release more cytokines, causing more localized destruction of the connective tissue. And the macrophages are recruited to the connective tissue. They release our cytokines, prostaglandin E2 and MM2, or MMPs, sorry. Okay, our established lesion. This is going to be established gingivitis, okay? Plaque biofilm extends subgingivally into the sulcus, disrupting the attachment of the coronal most portion of the junctional epithelium from the tooth surface, okay? More bacteria stimulate more cytokines, resulting in recruitment of more PMNs, macrophages, and lymphocytes. Plasma cells produce large quantities of antibodies to assist in controlling the bacteria. The immune system sends more immune cells, which release more toxic chemicals, and more healthy connective tissue is destroyed. Epithelial ridges extend deeper into the connective tissue and try to maintain their epithelial integrity. The junctional epithelium loses attachment to the root surface and transforms into pocket epithelium, which is thinner and more permeable, okay? Clinically, all features of gingivitis are accentuated. Periodontal instrumentation and patient education for good oral self-care are vital at this point. In some individuals, if bacterial infection is not controlled, gingivitis progresses to periodontitis, okay? We know that. But the plaque biofilm extends subgingivally, okay? We've already seen that, disrupts the attachment of the coronal-most portion of the junctional epithelium. Macrophages, lymphocytes are most numerous in the connective tissue. So really important to understand, established lesion, our most abundant cells are going to be macrophages and lymphocytes in the connective tissue. PMNs continue to fight bacteria in the sulcus. The host produces more toxic chemicals, cytokines, prostaglandin E2, and MMPs, okay? I'm gonna make this a little bit bigger here. There we go. Okay. So now we are to the advanced lesion, okay? Established lesion, guys, we still do not have apical migration of the junctional epithelium. We may have disrupted some of the coronal most portion of the junctional epithelium, so it may not be as long as it once was, but we do not yet have apical migration, okay? This is where in some individuals, if bacterial infection is not controlled, it will progress into periodontitis. But once we're to the established lesion, okay, that is where we have periodontitis, okay? The plaque biofilm spreads laterally as well as apically along the root surface, and the chronic inflammation causes harm to the periodontium. Our PMNs, macrophages, those cause destruction to the connective tissue and PDL fibers. The macrophages produce high concentrations of cytokines, prostaglandin E2, and MMPs that destroy the alveolar bone, okay? The gingival pocket progresses into a periodontal pocket. So a gingival pocket is when we do not have apical migration of the junctional epithelium, right? Could still be 4 to 5 millimeters if it has some pseudo-pocketing, and we've lost some of those coronal most cells of the junctional epithelium, right? But a gingival pocket is not yet a periodontal pocket. A periodontal pocket is when we have apical migration of the junctional epithelium, okay? Prostaglandin E2 destroys the bone by stimulating large numbers of osteoclasts to resorb the crestal bone, okay? Elevated levels of rankle modulate the osteoclast activity, which leads to greater bone loss. Destruction caused by the host's immune response overwhelms any tissue repair, okay? Clinically, periodontal pockets are detected. There's bleeding upon probing, bone loss, furcation involvement, and in really advanced cases, obviously we're going to see mobility as well. These changes are not reversible, the hallmark of periodontitis, okay? Factors influencing the host's failure to control bacterial challenge is abnormal PMN function, persistence and virulence of the bacteria in the biofilm, acquired and environmental factors like smoking and stress, systemic factors such as uncontrolled diabetes or genetic factors. Okay, so here's a picture of the established lesion. We have plaque biofilm grows along the root surface. The immune response becomes chronic, intense. Inflammation begins to harm the periodontium. Cytokines destroy the connective tissue and PDL fibers. The cytokines, prostaglandin E2 and MMPs destroy the connective tissue and the bone. Prostaglandin E2 initiates bone destruction. Osteoclast modified by rank and rankle for even more bone loss. Okay, so we can see the bacteria has invaded all the way past the connective tissue. Okay, and we can see PDL fibers being destroyed, bone being destroyed, and the junctional epithelium has migrated apically, right? Because it's supposed to be within 1 to 2 millimeters of the CJ. Okay. So at this point, we're seeing a sulcus step of 6 millimeters. Okay. And again, we're seeing all these, our TNF-A, our prostaglandin E2, our MMPs, interleukin 6, interleukin 8, and the TNF alpha. Okay. Bone remodeling. Despite its solid appearance, bone is in a constant state of remodeling. We talked about this a little bit when we talked about ortho. Bone remodeling is the breakdown of old bone and subsequent deposition of new bone. Okay. Our physiology of normal alveolar bone, the bone remodeling cycle is coordinated by interactions of osteoclasts and osteoblasts. Our osteoclasts are going to break down existing bone matrix, and our osteoblasts synthesize collagen and other bone proteins to lay down new bone. So in the resorption phase, osteoclasts create erosion cavities in the bone. The reversal phase is osteogenic signals stimulate the osteoclast to cease action. So they're saying, don't break down any more bone. Mononuclear cells adhere to the erosion cavities and send signals to attract the osteoblasts. Okay. The formation phase, osteoblast line erosion cavity and form a matrix to replace the resorbed bone. And then in the resting phase, this is the interval between cessation of bone resorption and bone remodeling. Okay, so bone remodeling is always happening. Okay, so this is a picture. The osteoclast breaks down the bone mineral and matrix, creating an erosion cavity. The mononuclear cells prepare the bone surface for new osteoblasts to begin building the bone. And then the osteoblasts form a matrix to replace the resorbed bone with new bone, and then it rests. Okay, so rankle, rank, and OPG pathway. Okay, so this is a signaling mechanism that occurs between osteoclastic precursor and osteoblast. So rankle is the cell membrane bound protein on the surface of an osteoblast. Okay, so and then rank is the cell surface receptor expressed on an osteoclastic precursor. OPG is the soluble secreted protein released by the osteoblast. Okay, so basically what's happening in all of that is rankle binds to rank to signal fusion of osteoclastic or breakdown bone cells. Okay, the precursors to differentiate into bone resorbing osteoclasts. Okay, so the cumulative effect of rank and rankle interaction is bone resorption. And then OPG blocks the binding of rank and rankle to protect the bone. Okay, so if rankle binds to OPG, bone is protected. Okay, if rankle binds to rank, bone is resorbed. And the ratio of OPG to rankle produced by osteoblasts determines the extent of bone resorption. But in homeostasis, the body attempts to maintain balance of OPG to rankle, okay? And that keeps our bone protected. In periodontal disease, there's an increased expression of rankle from the osteoblasts, okay? So, which is going to cause more bone resorption, okay? More rankle, if it's binding to rank, then bone is resorbed, okay? You guys talked about that in histology, I'm sure, the wrinkle, osteoclast, okay, just kind of bringing it into perio. So in bone resorption, again, we have activation of the osteoclast stimulates bone resorption, stimulated by wrinkle, PTH, calcitrol, and pro-inflammatory mediators, prostaglandin E2, okay? So we have wrinkle, prostaglandin E2, those are our big bone resorption things we want to link together. In our bone formation, we are going to have the inhibition of osteoclasts. Those are the cells that break down the bone. And then OPG inhibits the activation of osteoclasts so that it doesn't continue to break down. And then we see increased levels of estrogen and inhibitory cytokines. Okay, so that's why, guys, bone formation is a little bit more challenging for menopausal women, and they're at a higher risk for osteoporosis, okay? Because this isn't just the way that bone is remodeling in our mouths, but it's also how it's remodeling throughout our whole body, okay? So not having the estrogen makes it more challenging for bone formation. Okay, so the link between periodontitis and wrinkle-mediated bone resorption. So this is just showing the osteoblast, okay? It has influence of prostaglandin E2 and interleukin 11, okay? And then the wrinkle bonds to the immature osteoclast, okay, which stimulates the osteoclast to break down the bone, okay? All right, so I'm gonna try to play this YouTube video while my screen is still shared. Oh.
We also talked extensively about so like I mentioned in the very See you all next week.
Okay, I love his videos. They're so concise, but have like all the good juicy stuff in it. So good. All right, so now we are going to finish up our last chapter. Okay, so make sure, okay, we're still recording, all is well. Okay, so chapter 16 is going to be systemic factors that amplify susceptibility to periodontal disease. Okay, and we've already kind of talked about these a few times, just very briefly, and now we're going to get into why. So systemic conditions as a risk factor for periodontitis. Systemic risk factors are conditions or diseases that increase the individual's susceptibility to periodontal infection by modifying or amplifying the host response to microbial infection. The relationship between periodontal disease and systemic disease, it is a two-way street, okay? So certain systemic diseases and conditions are risk factors for more severe periodontal disease, and then periodontal inflammation may play a role in the etiology of some systemic diseases and conditions. Okay, so we're going to talk about that. Tobacco use, we know, diabetes, metabolic syndrome, leukemia, HIV infection, stress, osteoporosis, hormonal variations, neutropenia, Down syndrome, and medication side effects. So diabetes. Diabetes is a chronic lifelong metabolic disorder in which the body does not produce and or properly use insulin. So difference between 1 and 2. Again, you guys had a lot of that in med emergencies. But insulin is a hormone needed to convert sugar, starches, and other food into energy that the body can use to sustain life. The NHANES data, 21 million Americans are diagnosed with diabetes, and an additional 8.1 million Americans are undiagnosed, okay? The World Health Association predicts the number of adult diabetics will rise to 336 million by 2030, which, like, y'all, it's only 8 years from now. That's insane to see it rise from 21 million to 366 million, okay? Which means better diagnostic tools. Yeah, so you're seeing more people who were undiagnosed be diagnosed, but still, when you're talking about 30 million versus 366 million, that's pretty insane. And it will be the 7th leading cause of death, okay? Diabetes relationship to periodontal disease. So the prevalence of periodontitis is higher and symptoms are more severe in individuals with diabetes compared to with non-diabetics. Findings from studies indicate that diabetes leads to hyperinflammatory response to oral microbial biofilms and impairs the resolution of inflammation and repair. So we already talked about, guys, in a really healthy immune system with no underlying conditions, we can still see the immune response not stop when it's supposed to. And so when the body's already fighting something else, the prevalence of that continuing to go on when it should have stopped is going to be even higher, okay? Types of diabetes. So we have 3 different types. We have type 1, type 2, and gestational. So gestational is the diabetes that only occurs during pregnancy, okay? And for most women, it goes away after they give birth. But 5 to 10% of diabetes is caused by damage to the pancreas. That's type 1. Then we have 90 to 95% of diabetes. That's where the body does not make enough insulin in type 2, okay? And typically what we see with type 2 is that that is more managed with diet and exercise. Type 1, absolutely, they're still managing with diet and exercise, but even with perfect diet and exercise, type 1 is more genetic, it's not going away. Okay, type 2 is where we can see resolution in some patients or reversal of their diabetes with diet and exercise. And then, like we said, gestational just occurs during pregnancy. Individuals with well-controlled diabetes have no more periodontal disease than a person without diabetes. Individuals with poorly controlled diabetes are 3 times more likely to develop periodontitis. Guys, that's huge. 3 times more likely, okay? Individuals with diabetes who smoke are 20 times more likely than non-diabetics to experience severe periodontitis. That's insane also. Okay, glycemic control. Diabetes is well controlled if blood glucose levels are stabilized within the recommended ranges. And what reading excludes a patient from treatment in the clinic? So our A1C, the goal for most individuals with diabetes is a glucose level less than 7%. High susceptibility to infection occurs when the glucose level is above 8%. Okay, so that's why it's important to understand like where, when we're doing periodontal scaling and root planing, periodontal surgery, our ideal level for an A1C is going to be less than 7, because if not, we are going to have a lot higher susceptibility for infection and even more poor healing than you're already going to see because the patient is diabetic. Okay, our finger stick tests, which, you know, our A1C is the average blood glucose over a period of time. Finger stick is going to be that immediate reading. Okay, how much sugar is in the blood right now. Our target range, depending on the time of day, but target range is between 80 and 20. Okay, increased risk for infection is if we see sugars 180 to 300 in an unacceptable range, meaning a cutoff is greater than 300 milligrams per deciliter. Okay, subgingival microbia in diabetics. The composition of subgingival microbia in a diabetic patient is no different than found in a non-diabetic patient. Diabetes does not favor or influence growth of a specific periodontal pathogen. Meaning, just because you have diabetes doesn't mean you have more actinomyces or T4 Forsythia. Like, it doesn't, just because you have diabetes, it doesn't increase a certain bacteria or promote the growth of that bacteria. Okay. What's more happening is we have poor healing in diabetes. So unfavorable treatment outcomes may occur in long-term maintenance therapy in individuals, especially with poorly controlled diabetes, poorer response to non-surgical and surgical periodontal therapies, and more rapid recurrence of deep pockets. Other oral complications of poorly controlled diabetes, we can have reduced salivary flow, okay, which is going to increase the growth of Candida, okay, so oral yeast infections. You're going to have greater formation of dental caries, which diabetics are already at a higher risk for caries because of the increased blood sugars. And then multiple abscess formation. So rapid destruction of alveolar bone can cause abscesses. You can see angular cheilitis, okay, the fungal infection at the corners of the mouth. And burning mouth and tongue is going to be also more associated, especially with poorly controlled diabetes, okay? Localized tissue swelling of an individual with localized diabetes. So you can see the lateral incisor on the lingual has quite a bit more inflammation. Some pretty fibrotic tissue here in the lower anteriors. Periodontal disease with uncontrolled diabetes. These photos are really hard because it's like, yeah, is it diabetes? The tons of subgingival calculus, a combination of all of it, probably. So the effects of uncontrolled diabetes. Okay, so our lead to tissue destruction. Okay, so we have, where do we want to start here? Impaired host defense. Okay, reduced migration, impaired chemotaxis, okay, the release of PMNs, the enzymes, okay, collagenase and beta glucose or glucuronidase, increased tissue destruction, okay? And then over here, we have chronic hyperglycemia, which is going to also be related to impaired chemotaxis, reduced migration, impaired host defenses, and up to tissue destruction. We can go the other way, chronic hyperglycemia, chronic high blood sugar, monocyte and macrophage stimulation, cytokine, interleukin-1 and TNF-alpha, tissue destruction. Advanced glycation end products, capillary thickening, altered connective tissue fibroblast / osteoblast, poor healing, okay? Also going to lead to, boom, up to tissue destruction. And then advanced glycogen products can go down to just altered connective tissue, fibroblasts, osteoblasts, to poor healing. So pretty much everywhere this leads of uncontrolled diabetes, we have impaired host defenses, up to tissue destruction. We have chronic hyperglycemia causing tissue destruction or poor healing, okay? Both are not what we want in periodontal therapy. Okay, altered inflammatory response. So defective neutrophilic function in diabetics impairs initial immune response to infection. Hyperresponsive monocytes and macrophages in diabetics elevates the production of pro-inflammatory cytokines. And those pro-inflammatory cytokines may initiate and worsen the spread of other organ systems, causing other systemic conditions like cardiovascular disease. Imbalanced bone destruction and repair. Rapid alveolar bone loss seen in individuals with diabetes may result from uncoupling of activities of osteoblasts and osteoclasts. Prolonged osteoclastic formation and activity increases programmed cell death of osteoblasts, okay, which are our bone laying down cells, and impairs bone formation following bone resorption. So we're getting proper resorption, and we're actually getting too much resorption from the osteoclasts, and then it's going to increase the cell death of osteoblasts, so they're not getting anything else laid down, okay? The role of age and rage. So glycation, excuse me, is when glucose in the bloodstream irreversibly attaches to the proteins and lipids, forming harmful new molecules called advanced glycation end products, or ages. In health, age is low levels and non-pathogenic or non-pathologic effect to the body. In hyperglycemia, those advanced glycation end products is the formation is increased beyond normal and can alter the function of collagen. And then the age degrades collagen and elastin, causing these fibers to harden and lose elasticity. And then in diabetes, levels of age can contribute to neuropathy, retinal disease, and kidney failure. And then direct interaction of age to cell surface receptors, known as RAGE, triggers the pathologic tissue destruction. And then the receptors for advanced glycation end products, RAGE, are found on many cell membrane surfaces, even cells of the periodontium. Interaction with age and RAGE stimulates the release of pro-inflammatory cytokines, which leads to massive release of pro-inflammatory mediators. Okay, so this is just showing the periodontal microbia. We have the RAGE activation, impaired repair, and enhanced periodontal tissue breakdown, okay? Exaggerated sustained inflammation, okay? So, implications for the dental hygienist. Utilize user-friendly self-screening tools for diabetes to identify the risk. Educate about periodontal risks for uncontrolled diabetes, and be aware of food-focused behaviors. Interprofessional collaboration. Healthcare workers from different professions work together to deliver high-quality, patient-centered care. The dental team is well positioned to screen for systemic diseases like diabetes. Closer collaboration with other healthcare professionals makes it easier to educate patients about the relationship between disease and periodontitis. Okay, so usually if patients, like most of my patients in private practice, if they're diagnosed with diabetes, or if they start taking medication for osteoporosis, their PCPs or primary care providers are pretty good about reminding them to tell their dental professional, because they understand that it's important for us to know. It's also why it's really important to recognize medications. Like if your patient is taking glipizide or metformin or insulin injections, it's good to know the names of those, so that if they don't mark diabetes on their medical history form, but they're taking one of those medications, that you can identify it and know, oh, this patient also has diabetes. They need to be on a more frequent recall Typically, almost all of my patients that are diabetics, I have on a 3-month recall, which is something that their insurance covers and is better for the patient, okay? Because they're high risk for perio, high risk for caries, okay? Okay, stress. Stress is a risk factor for perio. Acute stress can be immunoenhancing, actually, but chronic stress can impair the physiologic regulatory mechanism that governs the immune system. Hormonal cortisol has anti-inflammatory and immunosuppressive properties. Blood levels of cortisol become elevated in response to physical and psychological stress. High financial stress and depression are significant risk factors for periodontal disease. Behavioral changes to stress include neglected self-care, changes in dietary habits, increased smoking and alcohol consumption, and non-adherence to periodontal maintenance schedule. I know we've talked about in class a lot too. I've told you guys, especially when you start seeing people on a really regular basis, you'll notice when something is going on with your life or with their life. And just by their oral conditions, it's pretty crazy. Prolonged or intense periods of stress can cause suppression of the immune system. This might tip the host microbial interaction in favor of the bacteria causing attachment loss. So this could be someone who you've been seeing forever. They've had chronic gingivitis, but no worries. It's been really, managed. There's no bone loss. And then all of a sudden they get a new job. It's really high stress. They get a divorce, whatever, something happens in their life. Then that scale gets tipped towards the bacteria and causes attachment loss. And stress can alter how people look after themselves, especially. You want to make patients aware of the potential effects of stress on general and oral health. So this is just showing that hormonal variations. I'm going to kind of click through these because we've been through these a lot. Okay, levels of sex hormones, puberty, pregnancy, menopause. It causes increased blood circulation to gingival tissues. Increased levels may cause increased sensitivity to plaque. Puberty gingivitis occurs equally in males and females. Usually patients who have gingivitis, pregnancy gingivitis occurs in patients who already had gingivitis, but sometimes you will see more inflammation during pregnancy. I'd say a lot of times you see more inflammation during pregnancy because people don't feel good, so they don't want to brush their teeth. But gingival inflammation usually increases in the second and third trimesters when elevated estrogen levels in the blood exaggerate host response. Second trimester is associated with increased levels of Prevotella intermedia. So P. intermedia uses estrogen as a substitute for natural growth factor. Okay. And elevated progesterone levels enhance the capillary permeability and dilation, resulting in increased gingival exudate and edema. High levels of progesterone and estrogen associated with pregnancy suppress the immune system or immune response to dental plaque biofilm. So this is pretty common. Pregnancy gingivitis, okay. Pyogenic granuloma, we've talked about these a lot, the mushroom shaped, okay. Dental x-rays. This is really going to be dependent on your doctor. Personally, as a provider, this, like my very personal views is that if it's not necessary, like if I'm a regular 6-month recall patient and I don't have any problems, if I was pregnant, I would skip it. If I had a toothache, I would take a PA. But I'm not going to take a full mouth series of x-rays on a patient while they're pregnant. And that's me. But there are some doctors that want that. So it is important to talk about your philosophies with the doctor that you work for. My doctor is like really conservative when it comes to pregnancy, which I really like. Like he's not going to do a simple DO filling while a patient is pregnant. He's just going to encourage them to keep it clean, and we'll do it after the baby comes. But really, it depends on the patient, their home care, the kind of practice you're working in, all those kinds of things. Menopause and postmenopause, we'll see decreased levels of circulating hormones in menopausal and postmenopausal women, resulting in oral changes, dry mouth, burning mouth, altered taste, bone loss may be exacerbated. Menopausal gingivosomatitis is characterized by gingiva that bleeds readily with abnormally pale, dry, and shiny erythematous appearance. Okay, so this is just showing the relative estrogen levels. Okay, drops off way at 60. Okay, osteoporosis and osteopenia. So osteoporosis is a reduction in bone mass, making women more prone to bone fractures. Osteopenia is a condition in which there's lower than average bone density, but not necessarily an increased risk for incidence of bone fracture. So this is just showing healthy bone here on the left versus bone with osteoporosis. Medication-induced osteonecrosis. So we were talking about bisphosphonates when patients are taking medications for osteoporosis. Most common prescribed medication to inhibit bone resorption. Bisphosphonates can cause a rare disorder called MRONJ, which is osteonecrosis of the jaw. Okay. Painful bone exposed in the mouth that fails to heal after an extraction or oral surgery. So it's really important to know if a patient has any history of bisphosphonates before doing an extraction, perio surgery, any of that. I have seen osteonecrosis a couple times in private practice, so it's not all that rare, but typically patients are really good about letting you know if they're taking bisphosphonates. Okay, this is just showing that estrogen deficiency and connective tissue destruction and alveolar bone resorption and tooth loss. So we want to inform patients about osteoporosis and interventions such as calcium supplements and weight-bearing exercises, stress meticulous self-care to avoid periodontal problems, and be aware of oral side effects of bisphosphonates. Metabolic syndrome. Okay, closely related to metabolic disturbances that occur together, increasing the risk of heart disease, stroke, and diabetes. So increased blood sugar, high blood sugar, increased blood pressure, high blood sugar, excessive fat around the waist, abnormal cholesterol and triglyceride levels, pro-inflammatory state, and increased tendency towards thrombosis. We're going to see a greater prevalence in older populations. In the United States, 1 out of 3 adults has metabolic syndrome, has an impact on periodontal status via chronic low-grade inflammation for a prolonged duration. And adipocytes or fat cells release adipokines, which cause sustained inflammation, insulin resistance, and increased susceptibility to periodontitis. And hypertension impairs blood flow that supplies the periodontium. Metabolic syndrome implications for the dental hygienist. We want to encourage patients to eat better and exercise. Okay. This just talks about obesity and how it's related to periodontal infection. It's also a lot of other things like home care is a little harder. It's harder for the hygienist to reach a lot of areas if your patient's really heavy, just because it's hard to get angulation because sometimes their chest is so high that your arm doesn't really have anywhere to go. Acquired immunodeficiency syndrome. So we have HIV infection, talked about HIV and the different things that we can see orally, candidiasis, herpes, Kaposi's sarcoma, linear gingival erythema. And this is linear gingival erythema. If you guys haven't talked about this and related to HIV, it's basically just like that classic red margin all along the free gingiva, okay? Typically not associated with pocketing, doesn't affect clinical attachment levels. This is a photo of it. This looks a little bit more nuppy because of the punch out papilla and the pseudomembranous layer. Safe to perform periodontal therapy as long as the immune system is competent. We want to have frequent maintenance visits, stress meticulous self-care, and coordinate with other health professionals. Most patients who are telling you that they have HIV are probably undetectable, okay? Meaning that they're on medications to where the virus is undetectable in their bloodstream. Alrighty, neutropenia is characterized by abnormally few numbers of neutrophils in the blood, lower than 1,500 cells per liter of blood. Leads to increased susceptibility for infection, can be a result of bone marrow failure, may be congenital. PMNs are the first responders to fight off the microbial invasion. Fewer means a poor immune response. Consider patients with neutropenia as being immunocompromised. So this looks like a really young patient because these are like some primary molars, it looks like. and maybe primary laterals even up here. And then we have permanent 8 and 9, 24, 25, 23, 26. But this looks like, yeah, primary T too. Okay, Down syndrome, a genetic disorder that happens before birth. Usually 3 copies of the 21st chromosome, also called trisomy 21. Biggest things that you need to understand with Down syndrome is the tongue may appear cracked with fissures, lips are large, and usually you're going to see macroglossia or an abnormally large tongue, malocclusion due to delayed eruption. Typically, these patients are going to have an increased risk for congenital heart defects, so we want to know if they have any congenital heart defects or need pre-medication. We're going to see abnormal numbers of PMNs, higher susceptibility of leukemia, GI abnormalities, respiratory problems. Often develop rapidly progressive periodontitis, substantial plaque biofilm formation due to poor home care. Periodontal pathogens colonize gingival tissues in early childhood years, may lead to loss of permanent anterior teeth. Early and frequent professional care. Patient may need help from caregivers, educate caregivers. Power toothbrush. Lots of attrition you see in patients with Down syndrome for sure, because they're big clenchers and grinders. But like, honestly, I have a couple of Down syndrome patients who I see in private practice, and they're like my all-time favorite. Like, they're just the sweetest, and usually they don't live as long of a life, which is really hard. But yeah, I love my Down syndrome patients, but lots of like food impaction and nutrition is the biggest thing that I see with them. Okay, leukemia, we've talked about this too. We're going to see swollen, glazed, spongy tissues, red to deep purple in color. It's going to bleed a lot, okay? Gingival enlargement. Oral mucositis is inflammation of the oral mucous membranes caused when chemotherapy attacks and kills the rapidly dividing cells of the mucous membranes. Cell dies faster than usual, usually 10 to 14 days. And we'll see tissue sloughing, okay? Xerostomia, salivary glands can be damaged during radiation. Reduced flow of saliva encourages more candida infections. So we want to look for spontaneous gingival bleeding, like we talked about before our midterm exam. If you see a patient with like just crazy heavy bleeding, not in conjunction with the amount of plaque they have, you want to just refer to the PCP and have some blood work done, okay? Pain management, you can use topical anesthetics, like a numbing mouth rinse. And then chlorhexidine may reduce frequency of oral mucositis and oral pathogens, okay? Systemic medications with periodontal side effects. So again, we've talked about these a bunch. A number of medications used to treat systemic conditions can cause oral complications. We can have alteration of plaque biofilm composition or pH, and an effect on salivary flow, and an effect on the gingival tissues. Sugar-containing medicines can alter plaque composition. Cough drops, cough syrup, tonics, vitamins. It's important to ask patients, if you see patients with a ton of cavities, especially dry mouth, if they're sucking on something to keep the salivary flow going, we want it to be like a xylitol-containing lozenge other than a cough drop. Or if they are using cough drops, if they have COPD or something like that, making sure that it's sugar-free. Okay. A lot of acidic things with vitamin C can lower the pH, okay, which is going to increase the risk for caries and perio, just because it provides a more ideal environment for the bacteria, okay? Can cause root surface caries in patients with perio, and like we talked about, has an effect on the metabolism of periodontal pathogens. The physical flow of saliva, though, helps to dislodge microbes from the teeth and mucosa surfaces. So salivary flow is really important for self-cleansing. And then saliva has an antimicrobial component. and components that repair and regenerate the oral tissues. More than 400 over-the-counter prescription drugs reduce salivary flow. Some medications, common ones causing xerostomia, blood pressure medications, diuretics, antidepressants. Another big one is antihistamines if patients have bad allergies. Patients with xerostomia also can have an increased risk of oral candidiasis, root surface caries, and excessive plaque formation. So all of these medications will cause xerostomia. Making sure these patients use an electric toothbrush. You can have them try a Biotene rinse. I like to recommend a lot of xylitol lozenges because those help to neutralize the pH after meals if they're not getting correct salivary flow. Also, if they put it up in their cheek by the second molar, right up by the parotid gland, it's going to stimulate the parotid gland, okay? And xylitol is the only sweetener that cannot be metabolized by strep mutans. So does not cause cavities and increases salivary flow and neutralizes pH, okay? Gingival overgrowth, we've talked about this a bunch too, calcium channel blockers and anti-seizure medications like Dilantin. Biggest thing, frequent home care and meticulous home care and frequent dental visits, okay? Anticonvulsants, immunosuppressants, calcium channel blockers, gingival overgrowth. We should know that by now. Okay, phenytonin is the anticonvulsant medication. Okay, Dilantin. And yes, sometimes gingival overgrowth is this bad, and this looks like a kid again, and you do the best you can because ultimately they need that medication to stay alive. So cyclosporines is the immunosuppressive agent. Usually only occurs in about 25% of people that take the medication. Looks really similar, really fibrotic. Nifedipine, this is a calcium channel blocker. 38% of people taking this drug will experience gingival enlargement. Okay, again, looks really similar, fibrotic. Okay, we want to be alert when patients share their medical history if they're taking any of those. Sometimes they can do like a gingivectomy, but if they continue to take the medication, it will just grow right back, unfortunately. So, all right, guys, like I talked about, we're going to do a quick review in class next week of these things that we talked about in the slides. But again, if you have any questions, concerns, feel free to shoot me an email and have a great rest of your weekend.